This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
So my name is Amir Matitiao. I'm an orthopedic trauma surgeon at UCSF and at San Francisco General Hospital at the Orthopedic Trauma Institute. I'll be moderating the session tonight here at UCSF. The session is entitled Mending the Injured, How Are Fracture Treated? And this is part of the Osher Mini Med School here at UCSF. Thank you all for coming. I know everybody's busy, have stuff to do. It's evening time, you know, family matters, etc. But we're very excited to be here with you guys. This is me. I'll give you a little bit of snippet about each person that's going to be presenting. I'm an orthopedic trauma surgeon, and I was trained in the East Coast, did a trauma fellowship at shock trauma in Baltimore, and then have been at UCSF since 2003. Dr. Jeremy LaRouche, he's going to be lecturing. He's an assistant professor here at UCSF and did most of his learning in Canada and is here part of our program at UCSF. He's trauma trained and spine trained, so if any of you have spine problems, you can catch him afterward, and I'm sure he'll be happy to give you some information there. And then Dr. Sam Morshed, MD, PhD, who initially went to Harvard and then did the rest of his training here at UCSF. And at Berkeley, he's an orthopedic trauma surgeon as well, and also interested in epidemiology, of which he has a PhD. So we're going to start a little bit about the history of orthopedic fracture care. And the reason why I want to do that is because I want to give you a little bit of background and kind of show you how things come around in full circles. We learn something, we forget it, we learn it again, we forget it, we do a little bit better, etc. And you'll see that even in 1600 BCE, there's a papyrus that was found that had 250 anatomical terms related to orthopedic surgery. I can't read that, but that's what I was told. And the incredible thing is, even at that time, they were worried about fractures, fracture care, taking care of people, getting back to function. Hippocrates even had these images of doing reductions, meaning straightening out bones and putting them in casts and splints in order to straighten out legs so people can return to function. And if we look at 1928, let's zoom forward to 1928, and what you'll see that happened in 1928 kind of brings in the modern era. And as we know that at that time, insurance companies started working, and an Aetna insurance adjuster said, it is questionable if surgery should ever be done except by highly trained people with highly trained assistants and highly trained hospitals. Otherwise, disaster is likely to result. And that is still true, right? I mean, you're not going to have random people doing surgery on patients. And he said that because he saw so many problems in fracture care. Non-operative treatment also has its own problems. For instance, open fractures, meaning broken bones that actually go through the skin and see the world, can have sepsis and death if they don't get treated quickly. Arthritis occurs because if you have a fracture around a joint surface and we don't put that back and make it nice and smooth, you can get arthritis. You can also get angular deformities. So imagine that you have a hip fracture or a fracture of the femur and you don't get that fixed. Your bones can be malaligned and short, and you can get a limp and deformity, and also length inequality. The problem with fracture care initially with casting was essentially people thought that prolonged immobilization is the way to go. And what happened really is what's called fracture disease. And fracture disease basically occurs around joints where you have stiffness, so nothing will move, or you have skin and muscle atrophy. So any of you that have had broken bones in the past, you know that if you get immobilized, what happens is that all the muscles get shrunken and you're not able to do what you were able to do before. You can also get localized osteoporosis, so you actually lose some of the density in your bone in that area. And you can get circulatory dysfunction. So some of the reasons why fracture fixation was a problem is because people would get sepsis from not good aseptic technique. So you would go and have surgery without prepping and draping, meaning that all the bacteria sitting there on the skin. You make an incision, and people get sepsis from that. Other issues were anesthesia. Obviously, awake patients don't do well, screaming and yelling. And implants that were used initially were made out of things like ivory and wood, and even metal that wasn't very adequate, and they were falling apart. So inadequate design, metallurgy, and I think Dr. Morshad maybe will talk about that a little bit. And then obviously complications from soft tissue handling. I want to show you some things that actually occurred before that. In 1907, Albin Lambat was an innovator. At that time, actually, he came up with things like, and as you see on the screen, plates, screws. He even fixed pelvis fracture at that time. So a very innovative guy, and he actually wrote a treatise on how to do this. So this is way back in 1907. And at that time, he actually created the first that we can find at least external fixator, meaning there's pins in the bone and an apparatus on the outside holding the fractures reduced and holding them together. And if you go back to 1921, the first intermedullary nail, meaning the first rod placed in a leg, in a tibia or a femur, was performed at that time. So pretty incredible. This got a little bit better over the years, and here's an example of 1942. This is during World War II. Actually, our soldiers from the United States went to Europe, and obviously there were some fractures that occurred. And they had tibia fractures like this, they had femur fractures, and this man, Gerhard Kushner, actually repaired their femurs with nails at that time. And he repaired the femur with nails, and we thought in the United States at that time that he was basically torturing our soldiers. But what he was actually doing is fixing him. This is some of the first examples of that. And you see here kind of the aseptic technique at that time that he was using. And you'll see, that's him there. You'll see that he basically winds up putting a rod down the tibia. This is 1942. Our technique today, and he's draping here. I'll move forward a tiny bit so we can move forward. That's the knee right there. He's making, don't look if you have a problem with these kind of things. That's the knee right there. And then this is, again, 1942. He makes a little hole in the tibia. You don't have to look, it's okay. And then, good thing it's black and white. And then he starts putting a rod down. And this is not much different. This is not much different than what we're doing today. So you have 3 orthopedic trauma surgeons here who do this exact thing to patients who have tibia fractures. Very, very common. So here's the rod actually inside the tibia and going down into it. And there he's knocking it back in. Okay, it's almost all the way in. Again, tapping it in. You can hear in the background, tick, 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 using a mallet. And then in the end, when he's all done, you'll see that essentially you have a little tiny incision this big, okay, when it goes all the way in. And that little tiny incision, that's it. So now he repaired a tibia with a little incision that was this big. So pretty amazing. This is 1942. And between now and then, there's been a lot of advances, especially with our technique and the type of implants, et cetera. But the basic principles are very similar. In 1949, this is kind of the first idea for plates and screws where you actually have fracture compression. So bone is very good with compression and very bad in distraction. So if we can put plates and screws on the bone and we compress the bone and have the bone ends kind of touching, the fracture does better. And this is the first time where you see actually interfragmentary compression, meaning the fragments are compressed together. And again, this is 1949. In the 40s and 50s, the incidence of permanent partial disability was very high. If you look at femur fractures, 70% of the patients that had femur fracture did poorly, and 35% of tibia fractures did poorly. They had 4 principles at that time. Anatomic reduction, rigid internal fixation, meaning the bones have to be rigid and don't move. Atraumatic technique, so don't kill the blood supply to the bones. And early pain-free range of motion. The problem is they had all these failures. These are all failures that you see here. All the way on the right over there, that's in the humerus, the upper arm bone, that's a hip fracture, and that's the elbow. So all these occurred because what they did was they made an incision and they looked at the bone, devascularized it, and basically put hardware in there. And the idea is that they basically forgot a principle that had been taught previously. And that principle was taught by Robert Girdlestone. I don't know if any of you have heard of him, famous in orthopedic circles. He said, bone is a plant with its roots in the soft tissues. It often requires not the technique of a cabinet maker, but the care of a gardener. So our job as orthopedic trauma surgeons is not to take bone and make it into a piece of dead wood, but to take bone and make it live. Okay, that's our job. And so the idea here is basically that when we do an open reduction, meaning we're looking at the bones and we're trying to put them back together, that causes bone devitalization. So that causes a decrease in the blood supply to the bones. On the other hand, if we do an indirect reduction, we're not looking at the bones, okay, that is soft tissue friendly. The problem with that is we're not looking at it, so it's harder to make things straight. Okay, that's kind of the balance. So you'll see recurring themes here, and I'm going to give it over to my partners here in a second. I think the evolution in fracture care is kind of a never-ending process. We're always learning. We're always getting better. Making progress is a collaborative effort and involves not just orthopedic surgeon, but a diverse group of people, including people who understand metallurgy, people who understand biomechanics, people who understand soft tissue management and physiology, and orthopedic surgeons. And if we stick to the basic principles we said before, you know, bone is not a dead thing. Bone is an alive thing. So you know the saying, dry as a bone or dead as a bone? That's not true, right? That doesn't happen. So bone itself, if it doesn't have a blood supply, doesn't do well. So we have to stick to that basic principle and solve complex problems. So I'm going to leave you with that. I try not to put too much information in these slides, just so we kind of have a flavor of what we're going to be talking about. And next up is going to be Dr. Jeremy LaRouche. He's going to come up and give us a talk about casting and how that's evolved. And what we're going to do is we're going to take questions at the end. And the reason why we're doing that is because this is being videotaped. So the way the videotape works is they want kind of the lectures to be in series, and then after that we'll take questions. Dr. LaRouche.
Thank you. Well, again, thank you very much for coming. As Dr. Matitiyahu mentioned, I'm an import. I'm from Canada, and I'm French-Canadian, so I got a little bit of an accent, and I speak quickly, so I'll try my best to slow down. I want to take over where Dr. Matitiyahu left off, and it's basically, you know, we used to think of the management of a fracture involving a cast. And if you've had a broken bone recently, or if you've ever been in a fracture clinic, you don't look around and see 25 people all sitting there with plaster Paris on their arms or legs. It's more of a rarity these days than what we used to have. And I want to kind of walk you through why things have changed in the last 30 years. So back in the day when my senior partners went to med school, you might have walked down to the orthopedic ward and saw dozens of patients in traction. This was a standard of care for a lot of femur fractures or tibia fractures. If you broke a bone, we knew that the bone had a pretty reasonable chance of healing by itself. But the problem is it takes 3 months for that to happen. And it's really important for us to get these bones to heal in a straight alignment so your function and your ability to walk and use your leg in the long term is not affected. So our treatment mentality was we admitted you to the hospital, we placed you in traction, where you had either pins sticking through the bone or your legs wrapped in different things, and we applied weights at the end of the bed to pull the bone straight, and you spend 6 weeks like that in a hospital, waiting for the bone to at least start to set, and then you spend another 6 weeks in a cast afterwards until the bone consolidated well enough for you to be able to walk on it. We don't see that anymore. I don't want to say we never use traction. We sometimes use traction, but we use traction as a temporary overnighter until your surgery the next day. So what's changed? It's easier actually to say what hasn't changed. So, you know, despite being fairly new in practice, I started med school about 12 years ago. And I bought most of my textbooks to use at that time. And I've lugged them around through 6 moves across multiple cities, now across 2 different countries. And the only book that I have that's still worth anything now is my anatomy textbook. because everything else in medicine changes so quickly that textbooks are irrelevant, except anatomy. That's still been around for a while, and it's not going to change anytime soon. I think the best way to show you what has changed is to give you a case example. So this is one of the most common fractures we see and we treat as orthopedic surgeons. This is a wrist fracture. So if I'm going to use the pointer, this is two different views. This is someone's left hand. So on this view, they're holding their wrist like this. And on the other view, the wrist is sideways like this. And what I like to point out is there's clearly a break in the bone here. It's what we call a fracture. So a broken bone or fracture is synonymous. They mean the same thing. And you can tell by looking at this break a few things. Number one, it's not a simple break. There's a couple of small extra pieces, so we call that some comminution. And number two is it's clearly not where it belongs. So it's displaced, it's angulated, and it's translated. If we let a fracture heal in that position, your wrist wouldn't move very well. Your muscles would be shortened, so your grip function wouldn't be as good, and you'd have an obvious deformity to anybody who saw you. So it's not a good outcome for anyone. So when we decide what to do with this fracture, we basically have two different options. Even what we call conservative treatment does involve treatment. We rarely ever just say, this will be fine, you don't need anything done. Most of the time we say, I need to pull on this, and that's called a reduction. We'll either put you asleep or we'll numb your arm or your hand, and then we'll be able to pull on it to line it up, and we're gonna hold it in that position with a cast. So that's what we call conservative treatment. The other option, which we do frequently as well, is called an operative intervention, operative treatment. And the majority of what we do as orthopedic surgeons in trauma is called an open reduction internal fixation. We make an incision in the skin, we move the soft tissues out of the way delicately, put the bone back where it belongs, and hold it there with plates, screws, or nails, or other implants. The decision what to do with each fracture is multifactorial and it's individual, but it comes down to the same thing. Every time your surgeon has a discussion with you, it comes down to a cost, benefit, and risk analysis. And more these days, we're trying to make sure that the patient is involved in making that decision as well. So rare is the day now would tell you saying, here's what we're gonna do, here's the plan. Most of your surgeons will come up to you saying, here's what I recommend. Let me explain to you the alternative and what's the benefit and what the risks are, and then we will make a decision together. So we call that having informed consent. The problem is even when we elect to do conservative treatment, there are risks and there are some disadvantages. A simple cast of the wrist can cause stiffness in the hands and fingers. It can be very difficult to regain your function. There is such thing as casting disease, as Dr. Matidiow said, where the skin becomes very sensitive and you get contractures that form and you have problems with the blood flow to the hand. It's also harder to hold a fracture reduced using a cast. We often get these malunions, or even sometimes the bone doesn't heal, called a non-union. What's the benefit of a cast? Well, it's quite safe, it's inexpensive, and it's easy. It doesn't require you to come to the hospital, wait a day or two for your operation, and spend a few more days and take time off work. It doesn't, in most instances, it doesn't cost you nearly as much as an operation would to your insurance. And some people are very adverse to surgery and very averse to an operation. There are lots of benefits we can get from an open reduction internal fixation. Namely, we're able to better restore anatomy and put the bone back to where it belongs and hold it there much more efficaciously. We can allow early range of motion because the bone is stabilized without having to stabilize across the joint. And as Dr. Matidiow hinted, if we're able to restore anatomy, we can often prevent late complications like arthritis. But there are many more risks to surgery. Anytime we cut the skin, there's a risk of infection. We try to mitigate that. We give you antibiotics, we use clean instruments, we do this in the operation, but it's still a risk that we have to consider. You could cause bleeding, damaging a nerve, the hardware could be painful, and sometimes has to be taken out, and there's still a risk that the bone may not heal despite all these. So, in the last 30 years, there's been three major things that I think have contributed much more to us being comfortable recommended on operation versus non-operative management. The first one is a swing towards what we call evidence-based medicine. The second one is significant, and we have much better implants. And the third is we're much better at putting those implants in with having different tools for imaging and navigation. So what is evidence-based medicine? There's been a big change in how things work in the last 30 years, and it's much more of less of a, this is the art of medicine, or this is how I've done things for 30 years, therefore this is how we're going to keep doing things. There's a much more focus now to have people critically appraise the evidence and be able to have to defend what they do, how they do it in front of their peers in order to be able to make sure that the best evidence is presented and we can benefit from everyone's knowledge. One of the ways we do this is by these things called randomized control trials. So if I tell you that I think it's better for you to have your wrist fixed with surgery, you can ask me saying, how do we know? And I said, well, I could say there's been multiple trials where we take patients and we actually randomize them. So we have them agree to be part of a trial and we say, I'm going to flip a coin. If you get heads, you get a surgery. If you get tails, you get a cast. And we actually get people to agree to this, surprisingly. We closely monitor to make sure that all the treatment groups get the same treatment and all the control group, the non-operative, are followed closely, and we measure their outcomes, and we compare them in long-term follow-ups and see who does better. And if you were to, this is our equivalent of Google. This is called PubMed. So if you Google the amount of research projects that have been done on distal radius fractures, as of 3 o'clock this afternoon, there are 5,752 papers related just to this one fracture. So the wealth of knowledge is astounding, and it's growing exponentially. And the reason it's very important is it allows us as surgeons to be able to do several things much better. Number one, it gives us a really good idea of what works and what doesn't. I don't have to rely on my own personal experience. I can rely on everybody else's experience and great studies to tell me what works and where we have improvements to be made. Number two is, even if I have a trick that works, I may be able to tease out which patients it works better on. So if I have a fracture which has an articular step, I know those do very well with surgery. If the fracture doesn't have an articular step, well, maybe I can get away with a cast. So even though I have all these tricks in my bags, it helps me to know who I should use what surgery or what procedure on. And lastly, it really does allow us to be able to benefit from the experience of hundreds of our surgeons that have done thousands of surgeries before. So it really does provide much better information than you could ever find in a textbook. Dr. Morshed, you're going to direct a lot of his questions to evidence-based medicine because he's one of the leading experts in the field and has done lots and lots of work in the last several years about publishing evidence-based orthopedics. So I think he'll be a great person to answer all those questions. Notice that deflection. The second thing is we have much better implants. And here's a good example. We call it hardware. It's a good old orthopedic term, putting hardware in someone. And if you were to have a broken wrist 30 years ago, your hardware would be a couple of pins that we would bend and stick outside the skin. And when you come back and see us at 6 weeks, we'd pull the pins out. And pinning the fracture is what we use to try and stabilize it. Now, we have implants that have much better metallurgy. They're custom designed to fit perfectly. And they have screws that are able to provide much better hold than we have ever had before. So these screws actually screw into the plate and rigidly hold the bone exactly where we want. So the best way to demonstrate this is a case example. So this is a patient who's had a very, very bad fracture to their knee, the tibia. Obviously, you can tell on this is a 3D CT reconstruction. It's very comminuted. There are lots of small pieces. The alignment is not good, so it's not lined up the way it's supposed to be. And there's lots of involvement of the joints, which, again, as we know, if we don't fix that properly, will lead to arthritis and stiffness in the long term. So thankfully, we now have implants that are exactly specifically designed for this fracture. So there's a plate that is meant to go on the lateral side of your proximal tibia, and it's shaped perfectly to have the right screws in the right spot and have the right contour. And there's a plate that's shaped to be exactly where it needs to go on the inside, called the medial side of your tibia. So this is an example of what we use inside surgery called fluoroscopy. So it's another version of an X-ray. So we can put the plate in, and initially you can see the fracture doesn't line up too well. But the nice thing about having plates that are pre-contoured is they're really templates for us to fix bone back to. If I put the plate in the right spot, and I put a screw in the bone, and I use the screw to pull the bone back to the plate, it helps me recreate the anatomy because the plate is the template for the fracture. So as you progress through the surgery and you can see that there's more screws going in and a couple of clamps, slowly and surely the bone's starting to look more and more like it's supposed to. And we even have implants that aren't metal, that are actually bone cement, which you can see here, that we use to fill the holes where the bone has been compressed or lost. And you can see that with the right implants, a very, very, very comminuted and displaced fracture could look like a fairly reasonable tibia by using the actual implants as a template. Even more, as we're getting to the future of orthopedics, we're saying that custom implants that are made for the average person may not be good enough. So we're now starting to 3D print custom implants. Right now, the indications for those are a little more reserved. If someone has a tumor and they have a tumor removed and they have a significant bony defect, we can 3D print something out of titanium to fill the void that matches their anatomy perfectly. We can template hip replacements, for example, that we do now that are exactly matched to that patient's anatomy, so they go in perfectly every single time. They're more expensive, they're more time-consuming to make, but it's becoming more and more accessible for the orthopedic surgeon to be able to use that technology to make the perfect implant, not just for the location of the fracture, but for the actual patient themselves. The last thing that's really changed, and I think I'm a big proponent of this, is we have better imaging and navigation. So one of the things I do, I'm a trauma surgeon, but I'm also a spine trauma surgeon, so I do a lot of spine surgery. And one of the things that's the bread and butter, the basis of what we do, is putting what we call a pedicle screw. Now, when you look at the textbook and you're in med school and you think about doing spine surgery, say, well, that looks fairly straightforward. You know, here's where I have to put the screw and here's where it doesn't go. I can do that. The problem is it's a little bit what we call tiger country, as one of my colleagues said, is there are dangers lurking everywhere. They're just waiting to jump out and get you. So what the textbooks doesn't show is that the spinal cord resides right there. The aorta resides right there. There are major nerves at each level that leave on either side. And when you're actually doing surgery, it doesn't look like the textbooks show you. It's kind of all, the anatomy is a little distorted, there's blood in the field, it's really hard to see what you're doing. And this is how we used to do spine surgery. This is a big, big incision. There's lots of damage to the muscle. And when you talk about the gardening mentality is you've just taken the plant, you've unrooted it, and then you're gonna put it back in and hope that it heals. This is after the correction with all these screws put in, and if you were to compare that to this as a model, it's really hard to figure out where these points are to put these screws in. Even using conventional x-rays doesn't help that much. It's really hard to orient yourself to know what's in, what's out, which screw you're looking at, and it's difficult. So more and more now, we're starting to use something called intraoperative navigation. These can be based on CT scans done before, ahead of time, that you've already had done, or the actual CT scan can be performed during surgery. And here's how clear we can see what we're doing now. This is where I want to put my screw, and this measures about 4.5 millimeters across, and my screw is about 4 millimeters across. So I've got about 0.5 millimeter of error to play with on either side. There's the aorta, there's the spine, and there's the lung. So if my screw hits any three of those things, I've had a really bad day as an orthopedic spine surgeon. So using this, it's a much more precise way to make sure we know exactly where we are, where our implants are going. And the advantage is, so there's a screw going in. The advantage is we don't actually need to see the bone to do this. So when you do an image-guided navigation surgery, it's actually done through little stab incisions. You don't strip the muscle off the bone. The patient has much less pain afterwards, and it's much easier to recover from as an operation. This doesn't just apply to spine surgery. This is a setup. This is actually a patient of Dr. Matitiahu's who had a vertical pelvic fracture. And there's traction being applied, so you can see it's just a little pin, and we're using this to pull the leg down so the fracture lines up again. But the problem is our conventional ORs, which were built 50 years ago, are actually too small for us to do what we need to. This is an intraoperative CT scan, which is used to spin the same way I showed you. This is a fluoroscopy machine, which we also use to get spot images along the way. And the surgeon's got to stand somewhere here and be able to look over the shoulder of the screen while they're operating this way in the patient. So it's really changed the game for us in terms of how we perform surgery and what tools we use to be able to get our fractures reduced and fixed. So overall, I think that the reason you don't see casts, and I just want to summarize my 3 points, is the following. Number one is we know much more about what works and what doesn't and what you could expect with surgery now because of evidence-based medicine. We have much better implants that are much stronger and easier to be able to fix fractures accurately. And lastly is we're better at putting them in because we have better technology to guide us during the surgeries without having to devitalize the bone. Thank you.
All right, thanks, Dr. LaRouche. Dr. Morshed is going to come and speak to us now. There's going to be a little bit of overlap, but he's going to talk about fixing fractures more in depth and really kind of what is the modern day of doing it. He also has some toys for us to kind of pass around so you guys can hold these things. Please give us those things back at the end. Thanks.
All right. Good evening. I have to thank Dr. LaRouche for convincing you all that surgery is a good way to fix fractures. That was the first half of my talk, but I just deleted it because you guys are all already believers. What we're going to spend the next 10 minutes maximum on is talking about whether what we're doing here is akin to carpentry or some sort of technical wizardry. I'm sure you all are very wowed by the prospect of surgical navigation and all of the great technology that we've had enter our field in the last few years. I'm going to try to convince you otherwise, that surgery is really not about that. It's about some things that are very principle-based, and it's not magical, and it's not carpentry. And I think it's hopefully something that you're gonna believe in even more now that you've attended this mini medical school course. The first thing to remember here when you think about technical wizardry is that surgeons only have one magical power, and it's our knowledge of anatomy. You heard that it's not changing much despite everything else in medicine that is just moving forward at an unbelievable pace. Anatomy really doesn't change, and a surgeon's only real power is their knowledge of anatomy, and that's one of the first things that I really emphasize to my students and residents. The second thing is that your surgical approach, your tactic, the way that you get after a fracture, impacts the biology of fracture repair. And when we talk about biology, we're talking about soft tissues, which have become increasingly important in our approach to managing fractures over the years. And I think you've gotten hints of that and flavors of that in the last two talks. And the third one is that fracture reduction and the way that we apply implants. So everybody, I think you've heard fracture reduction a few times. I want to make sure everybody understands what we mean by it because it's come up again and again, maybe not well explained, but fracture reduction means putting the bones back to where they ought to be, more or less. And you can do that very precisely in a direct way, or you can do it in more of a general gestalt way, and we call that indirect reduction. The way that we reduce fractures and apply implants influences the mechanical environment. And if you attended the other mini medical school course on this larger theme, you heard a little bit about how fractures heal. Some of them heal with callus, and we call that secondary fracture healing, or primary fracture healing, which is much more of a direct remodeling approach. It doesn't develop that big plume of callus. So we're able to influence that, and I think that's one of the really fun parts of our job, is really understanding how fractures heal and understanding our craft so that we can influence the way that a fracture heals, because we may want fractures to heal in one way sometimes and maybe another way another time. I should go back here. If you had a hard time with Amir's video, you should close your eyes during this talk. There are going to be some, some gross pictures. But this is what we do. And if I didn't show you pictures of kind of gross things, then I wouldn't really be telling you the truth about what I do. So here it is. This is a case, a patient of mine that I got to know about close to a year ago. This was a 13-year-old girl who got her foot caught in a motorcycle wheel doing some off-roading, and she presented to our Benioff Children's Hospital in the East Bay and was initially taken care of by some of my partners over there, and they asked me to participate in the care of this young woman. So what's happened, this is a foot. If you can't recognize it, it's sometimes hard to recognize really traumatically injured limbs. It's had a big portion of the inside part of the foot sheared off completely. This is an X-ray, which shows, again, a loss of most of the first metatarsal, some of the tarsal bones, the smaller bones in the foot, and it involves the joint. The joint between the body of the foot and the first toe, and in a lot of cases, this is an injury that is considered limb-threatening. I don't think whether it's a child or an adult, it's a limb-threatening injury. And I just want to tell you the story of this because I think it illustrates some of the way in which we think about these things. This is the same girl after several trips back and forth to the operating room. So we can't really get past first base in fracture, especially complex fracture care, until we've really cleaned the wound up. Okay, and this wound has now been cleaned. She's probably been back to surgery with me, and others a half a dozen times. And what I've done here is I've replaced the first ray, okay, the inside of the foot, the metatarsal, some of the tarsal bones, with a block of cement here, okay? And I've bridged this from the tarsal bones, the midfoot area, all the way onto her big toe with this dorsal plate. And this was followed by 2 free flaps done by one of my colleagues who's a plastic surgeon. None of this would be possible without that attention to soft tissue. That we don't go anywhere without soft tissue coverage of this wound, other than an amputation. This is what she ended up getting, which was a completion of her internal fixation. What we did was after about 6 weeks, the free flap, the muscle and tissue, as well as her fibula, the small bone of her other leg, was actually transplanted to this side and plugged into the blood vessels on this side. So she's got a piece of muscle from her thigh, and she's got a piece of fibula from her other leg, which have been transplanted over to this side. I completed the internal fixation 6 weeks later, okay? And went on and added another plate and screws, and we'll talk about plates and screws in a little bit. And this is her a year out. I just saw her in clinic actually last week. So you can see that she's got good range of motion. She's fused from her midfoot all the way to her big toe. And you can look at this, and especially trauma surgeons will say, ooh, you know, big whoop. You know, how is her function? You know, does she have chronic pain? How does this all work? Because it's not just about making pretty x-rays or pretty photographs. It's actually about making patients be able to function again, okay? And so, this is maybe an impressive case. There are a couple of things here that, most people would say, okay, this is a lot. She was lucky that she was, basically a child or a young woman. Her healing potential was tremendous, maybe more than me or you. But these are the kinds of things that we can get to. These are the kinds of outcomes that we can achieve by looking at some of the basic principles, okay? And so it's not about carpentry. Carpentry does not get that outcome. It's not about, just fascination with, medical technology. I mean, all these things help, but it's really much more, and I'm going to go back and we're going to beat this thing like a dead horse. It's about gardening. It's about understanding the living substrate with which we work, understanding what it needs to grow and heal, and providing the nutrients, the scaffold, the structure to get from that foot that is halfway sheared off to a foot that one can walk on again. So the goals of fracture surgery have changed very much. Early, in the days of Lambot and the founding fathers of internal fixation were very, very compelled by taking each little piece of bone and putting it back in its precise location. And we kind of lost the importance at that point, or it still wasn't completely evident to us how important the soft tissues were, that envelope, that nourishing layer, that protective layer around the bone that really mattered more. In fact, fractures and skeletal injuries, right? They're terrible injuries. They're terrible insults to the body. They happen to have a broken bone associated with them, but they're really much more of a soft tissue injury. And our modern approach to fracture repair really prioritizes soft tissue recovery, right? You see the breakdown in the soft tissues in this picture example here, right? That's a terrible outcome. That happens, and this patient is going to be miserable. They're going to need many, many additional surgeries, okay? We can get a bone to heal, even if it takes a long period of time, as long as that soft tissue envelope is carefully tended to. Then we get to bony healing, okay? So soft tissues are really paramount, okay? We need to understand what constitutes soft tissues, right? The skin, the muscle, the tendon, the blood vessels, nerves, all of these things that are vital to the function of that musculoskeletal unit, right? These things are what we need to prioritize. This was another patient that came to me shortly after undergoing an internal fixation of a very bad open tibial fracture, okay? And this is the wound that she showed up with. okay? So who thinks that's going to heal perfectly? Raise your hand. Okay, I wouldn't be showing it to you if it was going to heal perfectly. It's not. There's a zone of injury there that is tremendous, okay? And it was underappreciated at the time of the initial internal fixation. Again, I've had to, in caring for this young lady, deal with the wound breakdown, an infection that occurred subsequently. I've converted her fixation from internal fixation to external fixation temporarily while I get this soft tissue envelope under control. You can see that's the fibula there, that little white thing that's poking out there, right? Doesn't look so hot. And it wasn't. It was infected, and we had to debride it and clean up this soft tissue envelope so that it could be hospitable once again for recovery of this musculoskeletal unit. That required a free tissue transfer and staged reconstruction, kind of like what you saw with the young lady in the first case example. So this zone of injury, okay, what we think about is a soft tissue injury, the extent of which we do not completely understand when the patients initially present to us, okay, and often it takes days, if not weeks, for us to get to understand the extent of that. So let's get to principles of internal fixation, right? You've heard about this. I'm going to reiterate it. Okay, joints, we need to make joints perfect. Okay, I told you that we kind of have lost our fascination with making everything else look perfect. Joints still need to be perfect. They're like tires on your car. If they're not properly aligned, they're going to wear abnormally, and they're going to wear out, and you're going to end up with osteoarthritis or degenerative joint disease. So we continue to appreciate the importance of an anatomic reduction or perfect reduction of that bearing surface between two bones, okay? However, we only need to functionally align the rest of the bone. So then we talk functionally, we're talking about restoring its length, its overall alignment, its proper rotation, okay? That's what we mean by functionally aligning the limb. And by understanding how to functionally align the limb, we can step back from those really invasive surgeries that strip all of the nourishing periosteum and blood supply to the bone. Okay, we can step back and say, hey, you know what? We can indirectly reduce the shaft of that long bone. As long as we get the two ends in the proper location, we're okay, and we don't have to do all of that soft tissue violation to get there. We want to achieve adequate stability, and I'm going to get into this concept of stability in a second, to allow early motion. Because as you've heard in the first two lectures, it's really about getting motion back. Motion is so very, very important to patient-important outcomes, to avoiding stiffness, all right, to maintaining muscle quality, okay? These things really rely on us getting our patients back up and early. And in order to do that, we have to achieve some degree of stability in order to allow our patients to do that early on, even before the bone heals. In fact, a lot before the bone heals. Okay? And finally, again, doing this with a minimal biological insult. Okay? So stability is kind of a unitless concept. Okay, I can't tell you that, fracture A was stabilized with 10 stability units and another fracture has 25, and that 25 units of stability is way better than 10. No, that's not the case. We influence stability, as I mentioned to you, in the way that we work with the bone, we put it back in its place, our reductions, okay, and the way in which we use our implants, our tools in the operating room. So we start at the least rigid end of this spectrum with what you heard about earlier in Dr. LaRouche's talk, this concept of splintage, okay? There's no internal fixation or surgery there. That's a tibia that's immobilized in a long leg cast, okay? That is the least rigid of our interventions, okay? Now, this is an external fixator, okay? An external fixator is a device that's used to stabilize bone while minimizing the deep implant burden, okay? And so This is a fixator. This fixator is attached to the bone by these pins, and each of those pins are linked to one another by one or several bars, okay? And this is a way of achieving relative stability. Not a lot, not the same amount as a splint, just somewhere in between, okay? And this tends to favor secondary fracture healing, okay, or healing through callus. This is closer to the way we evolved to heal fractures, right? With not a ton of stability, you get this callus ball that forms at the fracture site, and gradually you have less and less motion at that fracture site where that elephant foot-shaped callus ball is, until the two ends bridge together and merge into one bone again. Okay, this is another way of achieving relative stability, but a little bit more. Okay, this is an intramedullary nail. Okay, and we're going to pass out some of these so you can actually put your hands on it and feel what they're talking. This is what Kuncher was banging in black and white on Dr. Matikyahu's video. Okay, and this is an internal fixation using a plate. Okay, and plates and nails can be used to generate varying degrees of stability, even within that category of internal fixation. We maybe have a little time to talk about that and show you some examples later. Okay? All right. So again, here's an external, these are two different types of external fixators. I tend to use external fixators in two ways generally. One is as a provisional type of fixation. So remember some of those pictures I showed you earlier, the young lady who had that wound breakdown, right, who ended up we had to pull the plates out and start all over again and do a free flap. What we realize now is that certain injuries can lead to really bad soft tissue injury, okay? And we've realized that we ought to wait sometimes in order for that soft tissue injury to resolve before we go for internal fixation. So that could be days or weeks sometimes. Okay, so we'll use these external fixators to provisionally hold things, to provide some stability, because that some stability actually helps the soft tissues recover more rapidly. So that's a provisional external fixator. Okay, this other type of fixator is called a ring external fixator, or an Ilizarov type fixator, after the Russian surgeon or the Siberian surgeon who developed these techniques many decades ago. Those kinds of fixators are used for definitive fixation. All right, there are scenarios in which a ringed external fixator actually may be a better way of definitively managing it. Rather than going to a nail or a plate, we definitively use this ring fixator, and I have an example of one of these here that you can take a look at as well, in order to definitively manage that fracture. Okay, so. And you can use an external fixator as a tool in the operating room as well. So that's maybe a third way in which we use this. We use them just for an hour or a couple of hours during surgery to indirectly reduce things while we apply our internal fixation. So there are these kind of hybrid techniques in which we're using multiple ways of reducing and internally stabilizing fractures. Plates. Plates are another standard, okay? There are thousands of different types of plates, and they have all different kinds of names. What's important to us as surgeons is the type of function that we're trying to derive from the plate, okay? I can use the same plate, okay, that one in the middle there, that LCDC plate, okay? I can use that to achieve absolutely rigid fixation, okay? If I take two bone ends and I mash them together using this device, or I can bridge an area where the bone is really blasted and hold it on either side with this plate and generate a more flexible type of fixation. Okay, so I can use the same implant here, the same plate even, to generate different types of stability environments depending on the fracture healing that I'm shooting for. Internal fixation by nails. Okay, again, these are all different types of nails that are used for different types of fractures. Okay, and again, I tell you that you can generate something that's very minimally stable to something that's very, very rigid as you move from the left to the right here, okay? And that has to do with the metallurgy, right? Are we using a very flexible type of metal, okay? Are we using a thin diameter nail, or are we using something that has a greater diameter? In fact, we can really influence the rigidity of our construct just by increasing the diameter of the nail. Okay, the rigidity of that nail increases by the 4th power of the radius, right? So this tends to be even more important than the type of metal we use, is actually the diameter of the nail that we put in a patient, okay? And we have cannulated nails, or slotted nails, or all kinds of different nails. I'll show you a couple of examples here in a moment. Depending on the stability that we want to generate in that fracture repair. Okay, so we've reached the end of this talk. Again, I want to really convince you that the knowledge of anatomy allows us to do so much of what we do in the operative management. It allows us to respect the biology of the fractures. Okay, and that understanding of the importance of the soft tissues has really revolutionized operative management of fractures. And finally, depending on the way in which we reduce the fractures and the way that we apply our implants, be they external fixators, nails, or plates, we can influence the mechanical environment and use that to achieve the type of fracture repair that we're trying to get at. Okay, now this is the end. These are the end of my slides. I have a few examples here of these different types of implants, and I'm just gonna pass them around here, and we've got plenty of time for questions now. This is an external fixator. This is this ring external fixator device. This is one that I tend to use as a definitive mode of repair. Okay, one, because it's very, very rigid. It's very flexible. You'll see that it has different struts that allow me to actually very precisely move the different bones relative to one another to achieve the appropriate position that I want. The other reason that I don't use this as a temporary fixator is because this costs more than the car that I drive. So it just wouldn't make sense to put this on patients for a couple of days. All right? So I'm going to pass this to Amir. Yeah, absolutely. So if any of you are interested, I'll pull up the software. There's a web-based software that we use to actually input the deformity, okay, or the position of the different bony fragments. And as long as I properly register the location of the rings with respect to the bone fragments, which takes a little bit of practice, I can correct virtually any deformity just by modulating the length of these 6 struts. So it's super cool. Okay, Dr. Matitiao is going to pass that one around. Let me show you a few others. These are medullary nails. Okay, and there are 2 different types of nails. This is a straight nail that we use for stabilizing femur fractures. Okay, very common. These have all been sterilized, by the way. Don't worry, I didn't just pull them out of my patients. Okay, and this is another nail here that we use for stabilizing tibial fractures. And as Dr. Matitiao said, this is so unbelievably similar to what Kuncher was putting into our expat soldiers in Europe during the World Wars. I mean, this is the technology has come a long way, but it's also very similar to what we used to use. These are 2 different varieties of plates, okay? This is an ancient plate. This one's been around for decades. It's still something that I use. In fact, I will tell most of my residents that, most of the techniques and even the implants that I use on the majority of fractures that I treat were invented before I was born. Okay, they were invented before I was born. Those don't change, just like anatomy. However, there have been some really cool improvements in technology. One of the improvements that Dr. LaRouche showed you is these plates that have holes that screws can actually screw rigidly into. These are called locked plates, okay? And so I'm going to pass each of these around. This one is a blade plate, okay? Yeah, it is. It's a blade, so be careful. Sharp. And these are just a couple of screws. Screws you've probably seen in hardware stores. You may not have seen cannulated screws, and so I brought a few examples of cannulated screws here. Cannulated screws can be used in multiple modes. They're nice because you can actually put a guide wire in and then run the screw over it if you're happy with the position. So a lot of times when we're doing these surgeries around dangerous anatomical structures, we'll use cannulated screws. Okay, and that's it. Those are really the tools that we use. I hope you've enjoyed this presentation, and I think Dr. Matiyahu, do you have more to present, or are we going to open it up to questions now?
Yeah.
Perfect. Okay, thanks very much.
So before we go on, the one thing I'd like to say is that just in summary, I think what you'll notice is that orthopedic surgeons who take care of patients with fractures have to know many things. So we have to understand the physiology, the anatomy, metallurgy, biomechanics, okay? How to apply all those things within the body. And so even though we just go to medical school and do orthopedic residencies, there's a lot to take into account. I mean, you saw even geometry. So all those things that your kids or grandkids or whatever need to learn in school actually become applicable later. Like even algebra. So we're going to open it up to questions now, and if you have we're going to bring the other two guys up here, and I'll have Dr. LaRouche point at whoever he sees first for questions, so I don't have to be in the hot seat. Yeah. So the question is, when you put the muscle back, what happens to the nerves? Do they grow back?
Yeah, that's a very good question. So most free tissue transfers are not innervated. Okay, so we're using them usually for the primary purpose of coverage and delivery of the nutrients that the fracture needs to heal, or to deliver antibiotics to an area that may have infection. There are some free tissue transfers that do include nerves, I'm not a plastic surgeon, so I'm not going to go into a lot of detail on them. Some of them are actually quite successful. I've had some patients who've had innervated free flaps, and they tend to work for cutaneous sensation. They don't tend to. We don't have as much success with transporting nerves that control musculotendinous units in terms of motor function.
So the other thing to say is, what is free tissue transfer? It's basically taking muscle, let's say from your thigh or back here, with its blood supply, meaning with the artery and vein, taking that and putting it in a different location, then plugging those back in. So plugging in the artery, plugging in the vein. And what that does really is, after a while, that muscle that covers an area that's missing muscle or missing tissue brings blood supply to that area. So it helps the bone, heal because of that.
Yeah, you do have some ingress of surrounding nerves as well that often come in. This is a process that takes months and years, but yes, patients often do begin to get some cutaneous sensation around as well.
Well, one of the things that we talk about is if you lose a nerve that goes to a muscle and that nerve is damaged beyond repair, we can't get the nerve to work again. But what we often do is take a muscle from somewhere else and transfer it to restore function to a certain part. So what we'll do is we'll do spare part surgery. So we'll take some muscle that is redundant, that you could still have the function otherwise, and then transfer that to restore maybe ankle motion or something else. So there is a way to get around that. It's a different strategy. The gentleman right behind you.
So the question, I'll boil down the question as I hear it. The question is, does the orthopedic surgeon basically take care of all the needs, or is there a multidisciplinary approach to patient care? In general, hopefully that summarizes kind of what you said. In general, traumatic patients who are after traumatic events, let's say come to the emergency room, and they get treated by a cadre of medical professionals, which include orthopedic trauma surgeons, but also trauma surgeons, general surgeons, urologists, internal medicine doctors, emergency room doctor, et cetera, and nursing care and physical therapy and social work. I mean, there's, so one person, you can imagine one person that goes through a traumatic event actually has probably 100 to 200 people that touch their lives, which start with paramedics in the field, let's say, and ends with maybe physical therapy and orthopedic surgery, et cetera, kind of on the back end. So you have a huge number of kind of people that take care of one person. So that's kind of a multidisciplinary approach that we use in orthopedic trauma care. I'll just start, and then I'll let Dr. Morshed or Dr. LaRouche finish. So the leg is made up of two bones, a big bone and a little bone, okay? In cats, they need the big bone and the little bone. In humans, the little bone is only needed really up high and down low to make the ankle and make the knee. Anything else you want to say there?
You summed it up, and we take the part in the middle, which has a blood supply. It has an artery bringing blood there, a vein taking blood away, and tends to take well when we move it to other parts of the body. People reconstruct jaws with fibulas. They reconstruct large bony defects with fibular transplants. So it tends to be an area that is pretty well tolerated. But it's a great question, right? I mean, you have to think, okay, if this person, if this attempt to salvage this limb is unsuccessful, and that young lady did need an amputation, then you would be taking a piece of her well leg, the one well leg that she has left. And so this is a dilemma that manifests itself in many different ways, this kind of robbing Peter to pay Paul, right? Where is it a good idea to actually, move something from one place to another? And especially in limb salvage surgery, this is a dilemma that we often have.
And just to play off of that for a second, the discussion, so what you're seeing here is you're seeing three people who, we do this for a living, right? And this discussion occurs all the time. I mean, I had the discussion yesterday with a family, something very similar to this. The issue is, in today's world, the discussion is kind of eyes wide open. So our job is, yes, we understand the anatomy, biomechanics, all those kind of things, metallurgy, but our job really is to try and convey that to the family and to the person who's having this injury, and to give them the options. Say, if I try and reconstruct your leg and it doesn't work, this is what might happen. If I take another step in a different direction, this might happen. And then you make a decision together, because, in the end, it's that person's leg, it's that person that has to live with it. I might have to do 30 surgeries. I have a guy right now who has had 23 surgeries, okay, to try and save his femur. And, that's a decision that we make together. It's not something that, no longer are we like parents talking to children, telling them what to do. Now it's collaborative effort, and it takes more than one person. Also, it takes a team. Sometimes we'll bring the plastic surgeon in so they can weigh in on what's happening. So it's kind of a team effort. So the question is, what is kind of the adverse reaction to materials that we're using, the metals especially? So, we use a diverse type of materials, everything from titanium to stainless steel. There's some absorbable materials, plastics, et cetera. The reality is that titanium doesn't really cause any problems. We don't see it. There are some people that we think have a nickel allergy that might have a problem with stainless steel, but those numbers are very, very small. Even patients that have a nickel allergy most of the time don't have a problem with the kind of stainless steel we're using. So the likelihood is very low. And sometimes we think it's happening, but we're not really sure. It's really hard to tell. But in those patients we're worried about, we take the implants out. It's a great question. I like Dr. LaRouche.
It all depends. So the spine screws, I don't use a drill. And the reason is the concept of a rapidly spinning 60,000 RPM next to the spinal cord, the nerve, or the aorta makes me very nervous. So I will actually use manual pressure and feel the bone using an awl to be able to make sure that I have that tactile feedback. When we do long screws, like the pelvic surgery that I showed, those are big screws. They're 7.3 millimeters across, or sometimes even bigger. I don't want to put a drill 5 or 6 times that measures that much before I get the perfect spot, because it'll cause a lot of collateral damage. So for those ones where it's hard bones, you do need a drill, we'll often use the cannulated screws, which we're passing around. which will pass a small wire, 2 millimeters first. We'll make sure we love where the wire is and it's perfect on X-ray. And then the screw's hollow in the center, so the screw goes over the top of the wire, but we know exactly where that screw is going because we already have a placeholder using that wire first. So it all depends.
So I'll give you one other tidbit, which is if you raise the temperature to 60 degrees Celsius, the bone dies. Okay, so yes, we pre-drill, especially in cortical bone or hard bone, or if we want to make sure that we're going in the correct direction, sometimes we'll pre-drill. And one of the reasons why that is because the bone temperature goes up and then you get necrosis or dead bone around that area. The other thing is to keep in mind is that, you know, you see our tools and you think, oh, you know, this is like drill, screw, you know. But the reality is all those things are tactile. We try and do them in a way that's very friendly to the bone and soft tissues. And we know the outcomes of patients that have poorly placed implants, especially things like the external fixator that Dr. Morshed showed. If you want that external fixator to last a long time, we actually have to pre-drill to put those pins in. And the reason why we do that is because if you don't pre-drill, a couple things happen. Either you strip the screws, or you can kill the bone, and then those get loose and they get infected. So
I just sit there during surgery when I'm operating with my residents, and my job is just to pour water as they're drilling to keep the bone cool so it doesn't burn. Seriously.
So I'll let Dr. Morshed talk about that. He's done a bunch of research on polytraumatized patients.
That's your question is a great one, and you probably need to apply to our orthopedic trauma fellowship at the Orthopedic Trauma Institute to really begin to grasp that. I mean, we're all still trying to understand that. There are some basic principles of managing somebody with multiple injuries. And just the way that we've come to appreciate the importance of the soft tissue and not get super carried away with putting all those little bitty pieces back together, we've also come to understand the importance of the physiology of our patients and how much they can take at any given time. And it turns out that really badly hurt patients can't take too much surgery. It can make them really sick. Sometimes it can even kill them. So we need to really, really be careful about timing surgery, okay? Certain things need to be done sooner than others, okay? So sometimes the soft tissues are a big problem. They may have a lot of swelling in one of the compartments of their leg. That's an emergency. Almost no matter when that patient comes in, if they are developing too much swelling in the leg or the thigh or the buttock or somewhere else, we need to release that pressure. Okay, that's not even a bony procedure. Again, that's taking care of the soft tissues, because if those soft tissues aren't good long term, the patient's not going to do well. Over time, as the patient is resuscitated, okay, as their overall physiology calms down, we can begin to start knocking out one injury after another, and we tend to start with big stuff. Right? Patients actually benefit from having their femurs fixed, sooner than later. Sometimes if it looks like they're going to be so sick that we're not going to get to it for days or even weeks, what we'll do is we'll put on an external fixator, right? Minimal burden to the patient, doesn't stir up a lot of bone marrow, doesn't cause a lot of bleeding. We can do it with minimal impact on the patient. It stabilizes the musculoskeletal unit, makes it easier to take care of that patient in the intensive care unit, resuscitate them, so that when they've gotten to the point where they can handle more surgery, we can begin to put them back together. But spine, long bones like the femur, these are things that, as soon as the patients are well enough, those are what we tend to start with. The little finger fracture, the little toe fracture, those are things that we can wait a little bit longer on.
So the way we just, big picture, life before limb. So first thing is we're trying to save their life, and then after that we'll think about their limbs. That's the first big picture. The second one is that we know that our surgery causes trauma. So the patient comes in, they've had a trauma. They got hit by a bus. We just had a lady that hit by a freight train. So those patients come in and they have a huge hit to their body. All that energy, so the other thing we have to understand as orthopedic surgeon is kinetic energy. So kinetic energy is 1/2 mv squared, right? 1/2 times the velocity right? Times the mass times the velocity squared. So we know that energy gets imparted to the body and they break things, okay? That's the first hit that they get. So that's the first trauma that they get. We know that whatever we do will be the next hit, the next trauma. So us doing surgery also causes them to have a trauma. So we have to time that correctly so that we don't make it worse. We want them to be, as you said, resuscitated, to be more physiologically stable before they can take another hit that we're going to give them. Okay, so that's kind of the two things kind of in our mind that we're thinking just kind of over the big picture.
Yeah, so when you're young,
What was the question?
oh, sorry, I'm going to repeat the question. So the question is, what happens to your bone marrow when we put a nail down and we displace that bone marrow? So in a pediatric patient, in a child, that bone marrow is an important part of their system because it makes blood cells. By the time that you're fully grown, the majority of your long bones gets replaced with fat in your bone marrow. It's no longer that hematopoietic cells that are living there. So it does get displaced. And it's a good question you bring up because one of the things that we just talked about is when we put a nail, we know that we're going to displace that bone marrow. And in a very, very sick patient, some of that bone marrow escapes into the small blood vessels that go in and out of the bone, goes to the lungs, and can actually cause problems. So it's a great question as a follow-up to what Dr. Morsha was talking about, because that's one of the things we consider before putting a nail in someone is that, we know we're going to displace this bone marrow. It doesn't affect them from the point of view of their ability to make red blood cells, because by the time they're an adult, that bone marrow has been replaced by fat and long bones. But it can cause more damage to the patients that we're trying to help. So it causes another little trauma. So that's why we have to make sure that the timing of our surgery is appropriate to make sure that we don't make them sick, we actually make them better. It's a great question.
So I'll tell you that post-traumatic arthritis in the knee is pretty unusual. It happens, meaning after like a tibia plateau fracture, like Dr. Morsha or Dr. LaRouche showed up there. It's unusual, but it happens. The reality is that knee replacements are so good that to show a better knee replacement, it takes 15 to 20 years. So the original knee replacement or hip replacement done by Sir John Charnley in England in the 70s is still the gold standard, meaning that, I hate to, kind of kills an industry, but, all the stuff that you see that's, patient-specific, that costs a lot of money, is not doing any better job than the stuff that basically has been around for 20 years. There's incremental changes, little changes, but not huge changes, because it takes a long time to show that a knee or hip replacement does a better job. It doesn't take a year, it takes a decade or two. So as far as post-traumatic arthritis, I think that what's left today are things like osteotomies, so moving the bone a little bit so the weight gets transferred a little bit differently, or things like knee replacement or hip replacement. The other option is also fusion, so you basically get rid of the joint and the bone basically is fused together so it doesn't hurt. But it really depends on situation, age, what's available to you. I mean, there's lots of factors involved. In the red, yeah.
Absolutely. I mean, that starts. The question is, when you're applying an implant, such as a plate, do you have to worry about where the ligaments may be? What is the relationship between the surface in which we apply an implant or the place where we cannulate a bone in order to apply a nail? It absolutely matters, and this is why getting your anatomy right is the very first part of becoming a surgeon. You cannot go beyond any very basic step without that knowledge. That is absolutely critical. And different structures have different degrees of importance. There are some areas where it's not a big deal. We can put a screw through a ligament and it's going to be okay. Other places no. And so I don't have a simple rule for you other than understand your anatomy if you're planning on doing surgery anytime soon, and you'll get it right. You'll understand it. But absolutely, your surgeon is constantly thinking about this stuff when they're thinking about how to perform the right surgery for a fracture.
One other thing I'll say, which is going back to the blood supply. Keep in mind that we put plates on bones. We're putting screws in there, and those plates are pushing on the bone. And underneath the plate, what happens is the pressure is so high that it can actually get a little bit of necrosis underneath the plate. Okay, So we're very aware of that, and that's why we're talking about blood supply. There's something that covers the bone called the periosteum. That's the kind of covering around each bone, and that has a very important blood supply that feeds the bone. What we try to do is not crush that with our plate. So that's kind of a corollary to your question, which is, how do you save the structures underneath? That's one of the things we're trying to save, is that structure that actually supplies blood to the bone.
Yeah, periosteum is sacred. If you were here last week, you learned even stem cells that come in and actually help repopulate the fracture callus and contribute to that bone healing process come from the periosteum.
So it depends where those fragments are. If the fragments are part of a joint, then it makes for a long day for any one of us because we try to get them perfect. And that's really important to try and get those fragments to line up. So the cartilage in the joint is what allows your joint to move smoothly. And if there's a jagged little edge because a piece of bone is flipped the wrong way, that's going to cause a lot of friction and it's going to wear out. The problem is you're born with certain things you don't get any more of. Brain, heart, spinal cord, and cartilage, what you're born with is what you get. So you don't regenerate a new one very well. So that's important for us to get perfect. If those jagged little edges are part of the shaft, as Dr. Morsha was saying, if they zigzag, but my knee and my foot are in good positions relative to one another, they're the right length, they're the right alignment and right rotation, I don't have to worry about getting every single one of those little pieces right. They'll heal by secondary intent, which means they'll form a big ball of callus, and eventually, specifically in kids, as they get older and the bone gets longer, it actually remodels and looks more and more like regular bone. In adults, we don't get that ability to remodel as much, but it does happen just slower. And it's not as important. It's not like you'll look at someone and say, you look like a deformity that you see it. We can accept a lot in the right places, and we can't accept any deformity in other places.
So just a little more color. So articular cartilage. So cartilage that is between bones has a little fluid in there called synovial fluid. It's kind of like grease. You put two bones together, like your knee or your elbow or your shoulder, and the movement there is so smooth, the coefficient of friction, how much friction is there, is 10 times better than ice on ice with water on it. Okay? So your body is so good at creating smooth and gliding surfaces, much better than other things that we see that we think of as smooth. Okay, that's the first thing. The second thing, if I had to take all those little pieces and put them together, I would devascularize them, meaning I'd get all those pieces in the middle of the shaft of the femur or in the middle of the forearm. So what I'm trying to do is actually bridge those and leave those tiny little pieces alone so the blood supply stays on them. If I have to put them all back together, what happens a lot of times, I get rid of the blood supply there, and they basically die, and they leave a defect, and what happens is you get a non-union. So the older teaching was, as we said earlier, anatomic reduction of everything. So everything has to be perfect, aligned, perfect together. Today what we're doing is we're trying to create a bridge over things that don't matter, that we don't have to touch. Okay? So we leave the blood supply alone. We leave the soft tissues alone in that area.
Yeah, the one part that I left off, so the question was, so first of all, on this plate that I think has made the rounds, you all have seen this plate. It's serrated on one side of it, okay? This is what we call a low contact plate, okay? And the idea here is that these scallops here in the plate minimize the contact between the plate and the bone underneath it. And so that, at least theoretically, is meant to improve the blood supply to the bone by way of the periosteum, which is not getting smushed. Okay. The second question. The second question is the external fixator, the ring fixator that you saw traveling around the room. People are wondering, how does that actually stick to bone? Yes, in fact, each of those little holes in the rings that you see there can take a nut and a bolt which attach to it, either a skinny wire or a thick pin, which is used to fix the fixator to the bone. Okay, those have been taken out and tossed because this actually came from one of my patients, and those are non-sterile parts that we don't want to expose you all to.
It's interesting because robotic surgery's made a lot of leadway in certain things like prostate surgery, for example. So there's robots that are well known that do that. There's been some attempts at using robots to try and make total joints, which is a surgery, which is kind of a, we joke around saying the beautiful thing about being trauma surgeons is no two cases are the same. So you kind of stick to principles, and you kind of have to adapt to the scenario and do what's best for that patient in that particular condition. I would say total joints is almost the opposite. You're getting paid to do the exact same 125 steps the exact same way every single time to get the same results. And people have said, well, maybe we could use robots to help that. And as Dr. Matitiyahu said, the problem is they do so well with doing joint replacements today that to make it better is so hard to find that increment that makes a real difference that it hasn't manifested itself that well. A few people have tried for their spine surgery as well, and it's not mainstream because it hasn't made that difference. It hasn't had that benefit that we've been able to demonstrate to make a big difference. And it's costly and it's time consuming. It's a lot of resources as well. So maybe in the future, but it's not mainstream by any means now.
Can I say something just as a bit of advice? Just be really wary of advertisement in medicine. All right, you all are here in medical school now. You're all medical students, and I think one of the first things I learned in medical school, and I still remember it, was to be really skeptical about technology. There are wonderful promise to technology in the biologic sciences and the implants and the devices and there's a lot of great things around here, but it's almost funny for one of us to pick up a journal and when you're getting on an airplane and you open the page and you see Laser Spine Surgery Institute. And nothing against that particular entity, but I don't know what laser spine surgery is, and I'm an orthopedic surgeon.
I'm a spine surgeon.
He's a spine surgeon, and he doesn't even know what laser spine surgery is, And so you'll hear these kind of fancy technological terms added to pretty routine procedures, and I would urge you now to really be critical thinkers and really think critically about these pitches that are made for various types of technologies out there.
So I'll just say one thing, which is, remember we basically talk about 3 or 4 principles. So everything that we do as orthopedic trauma surgeons essentially boils down to a few very simple principles. If you can use technology to help you with that principle, makes sense. If you're using technology in order to create fluff, doesn't make sense. Okay. So for instance, you saw that we have an intra-op CAT scan, et cetera. I use it to be very accurate. Okay. I use it as a tool to be very accurate. It's not actually something we advertise. You're not going to see me on, some thing, advertising it. I'm using it as a tool in order to get accurate results, to make sure that I'm putting screws, let's say, in a very narrow corridor. And there are some other orthopedic trauma surgeons that may send me a patient because they can't see what they need to be able to see because they don't have this tool in their armamentarium, okay? So that's a specific reason to use kind of technology. But you really have to think about what is it that people are advertising to you, what is it they're telling you they're doing, and does it make a difference? Is it actually something that creates a different outcome for you, or is it just, a way to get you in the door?
Yeah, the answer to the question is even now, a lot of the spine surgery that is done is fusion surgery, where we stop motion across painful, deformed, or fractured joints. And the question is, has it been replaced or superseded by new replacements? So there are a lot of disc replacements, for example, so either cervical disc replacements or lumbar disc replacements that are on the market. There are also implants that are designed to allow some flexibility. But the problem is when they go head-to-head in randomized controlled trials that we've demonstrated, a lot of them are inferior to the gold standard, which is still fusion. So for the lower back, even though there's lumbar disc replacements that exist, there hasn't been a single study that shows that patients do better or have fewer complications in long term as compared to people who just get their back fused. In the cervical spine, I would say the jury's out. There are disc replacements that are being done now that show great promise. But as Dr. Matitiyahu said, the problem is our benchmark for success is not, is that still doing well 1 year after surgery? It's, are they still doing well 20 years after surgery? And we're not at the 20-year mark yet. So they look really promising. They look great. I talked to my patients about some of them about it, saying you could consider this. But I said, I can't tell you honestly with my hand on my heart that they do better than a fusion. I'll tell you in 15 years from now, because then we'll have a 20-year track record. Do you want to be part of the study or not?
So when it comes to devices, don't go for the latest and greatest. Okay, look, ask your surgeon, and hopefully you find somebody who can be honest with you, and ask him what's been shown to work for a long time. That's the kind of surgery I want, is boring old surgery. That's a great question. That woman would probably, if that woman who you saw in the case, the 13-year-old girl, had been 80 years old, she most likely would have gotten an amputation. Yeah.
So the question is fixation of osteoporotic bone versus fixation of normal hard bone, say non-osteoporotic bone. There are actually technologies that help us with that. That's one place in the last, I'd say, 10 to 15 years where advances have been made which have dramatically changed how we do practice. The population is obviously getting more and more mature, and our patients older than 65 years old are becoming more numerous. And so we're lucky that in the last 10 to 15 years we've had technologies that help us with that. And one of those technologies is what Dr. Morshed showed, which is what we call a locking plate. A locking plate is where the screw head actually locks into the plate. So it's metal to metal kind of construct, and that creates kind of unity between the screw and the plate, and it doesn't rely on pulling out of the screws from the bone. Because normally what happens is, as you put a screw in, you're relying on the pull-out strength or how easily the screw pulls out of the bone. Once you have a locking plate, it just, they're kind of held in space. So if you actually put these things in a banana, they hold, how soft the banana is, they come out basically all at once. So for all of them to come out at once, you'd have to have a lot of force, even in osteoporotic bone. So this is kind of an advance. So, and we find actually that osteoporotic bone can heal just as well as regular bone, as long as the person is not vitamin D deficient, they're taking enough calcium, et cetera. And as you know, in our population, this is just to throw it out there, in our population, 30 or 40% of our patients have vitamin D deficiency.
In California?
In California, so in this location. So it is important to think about taking vitamin D, getting out in the sun, calcium, et cetera. We're not going to go into that. So we'll end there. I'd like to thank everybody for coming. I'd like to thank my two partners here for doing a great job. As you all know, the Osher Mini Medical School is continuing to do great work and opening kind of medicine to you guys, and we really appreciate it, and we're very happy to have the opportunity to be here with you. Thank you very much.